What if we just had a monitor right
We're
here?
good? We're good. All right, let's start the Human Services Committee meeting. Are there any courtesy from the floor comments? Seeing none, we have a report tonight on the Drug and Alcohol Division from the former director, or no, from Sue Wondolowski.
No, it will be from the former, but I wanted to announce.
What happened?
Our former. No, this is good news. It's okay. So,
Always an exciting moment. Go ahead. You don't have much time.
and I have a long list. So.
Yes, you do.
So, Tiffany Rossinis was our drug and alcohol administrator as of this past Monday. She is now our mental health early intervention developmental program administrator, but she was already stuck on the county council docket, so she came to update us on drug and alcohol. So I wanted to introduce her also as our new mental health MHEIDP administrator. Please welcome her, and she will give us our drug and alcohol update.
Is she going to give? Are you going to give both reports actually, or?
I have the MHEIDP
Okay.
stuff. So
Don't put her
Just
on
checking,
the spot.
because we could just go one to the other if that was easier.
I let her off the hook.
She's
Okay.
I'm only 4 days in. I can't really give you too much of an update on that
excuses.
one.
I know, this is quite a frenetic
Um,
incident.
So Sue asked me to come and report on drug and alcohol one last time. I did give you packets, and in the packet, one of the big things that we worked on this year, we're a part of a task force. It's the Northampton County Opioid and Heroin Overdose Task Force. It's headed by Kristen Wenrick, who is the head of the Bethlehem Health Bureau. And she did a lot of work gathering data because we had a hard time tracking overdoses and getting data. And we've used this data for a number of things, programming that we're doing, and I'm going to just kind of touch on a few of them tonight. But I did give you a copy of her report, which is from 2015 through 2017. And one of the highlights just from 2017, there was 558 overdose deaths in Northampton, or overdoses in Northampton County last year. 109 of those were resulted in death. So our numbers have continued to climb. We don't have the most recent update from the coroner for this year, but we are unfortunately on pace to beat that number for this year. One of the things that she pointed out in there, she was able to pool by zip code as to where the overdoses were occurring. So two of the highest places were in Bethlehem, 18015, 18017, the city of Easton, 18042. But the one that kind of stuck out to us and that we're addressing is 18067, which is Northampton. And a lot of times we talk about the Slate Belt and how the Slate Belt, there's underserved up there and a need for service. But there's a population of people. I'm a borough resident, so I speak for my borough. Northampton Borough, Danielsville, Walnutport. There are no services up there. There's actually one, maybe two 12-step meetings in that whole area. So our residents are driving to Easton, driving to Allentown. So we took that information, and one of the first things that we're doing as of July 1st is opening the Northampton Recovery Center. It's going to be on Main Street. We're calling it Change on Main, very creative. We currently have 3 in the county. We have 1 in Bethlehem, 1 in Easton, 1 in Bangor, and now we'll have 1 in the borough. Currently we're doing construction. It was an old dance studio, and it will be ready to go July 1. They started June 1st doing construction. July 1 they'll be up and running. Lehigh Valley Drug and Alcohol Intake Unit is going to oversee that program for us. They oversee Bethlehem and Easton as well. And we'll offer 12-step meetings, different classes, yoga, mindfulness. We'll have sober events. And we'll also have certified recovery specialists on site there that can meet with the clients from that area rather than having them go to Easton or Bethlehem. So we're really excited for that. We'll let you know when it's officially opened, but July 1st is the target date. The other thing that we started last year, halfway through the fiscal year, and we're going to continue it because it's been very successful. We have outreach workers. They are targeting the Bethlehem area, and then we have one that does Easton and the Slate Belt. And the 2 workers are going out. They're going to doctors' offices, clinics. They're out under the bridge with the homeless population. taking out little bags, giving them information on how to get help. We have personal care items we're taking out with them. But they've really been doing a lot of outreach in the community, and we've actually had success with people walking into drug and alcohol intake unit and saying, I got this information from your outreach worker. So the whole goal was to engage people into treatment, and it's working. So we are continuing that program. We have grant funding from the state. It's called the Cures funding. And so we made sure that we're going to continue it for this year, and if we need to expand, the new administrator, whoever that may be, will work on that. Another program we're doing, and I gave you handouts on it, it's called B-Pair. Depending on the police department, it could be C-Pair, it could be E-Pair. We haven't, it started as B-Pair. It was Bethlehem and Bangor have taken this on. Any person can walk into these police stations, go in and say, I need help, without the fear of being arrested. They are checked. If they have an active warrant, they do need to take care of that. If they're not clear, they call, the police officers call one of our assessors that's on call. They're going to the police station, assessing them, and linking them right to treatment. It's kind of been a slow, it started out fast, and it kind of faded out, but the Health Bureau and the police departments have been doing a lot of outreach and promotion of it. And to the point that Colonial Regional contacted us, and they wanted to come on board. So we have Colonial Regional has been trained. Lehigh Valley Drug and Alcohol Intake went out and did training for them, and they are on board, and we are currently finalizing talks with Easton to bring Easton on board. So it'll be 4 police departments. It is all grant funded right now, so we're hoping that continues. But this all came, again, out of that task force that we are on with the Bethlehem Health Bureau. And then since the numbers were kind of low, what happened is the assessor who's on call, she's also our outreach worker. She wears a lot of hats. She's a certified recovery specialist. She is actually going with the police. I think it's about once a week. They take the list of individuals who have overdosed. So they may have never have made it to the hospital. They may have been Narcan, woken up, and said refuse treatment. She's going with the police officer to their home, and they're doing outreach that way. And they've actually been able to get individuals who maybe a week ago in that overdose and all that was going on said, I'm good, but now they're saying, yeah, I want treatment. So she's been going out. They tried phone calls. That didn't work, but the face-to-face that they're doing, Chief DeLuzio said, has been working out really well. So eventually that may expand, but we've had a lot of success with Bethlehem just because their health department's on board, Chief DeLuzio, their EMS. So we're piloting a lot of the things in the city of Bethlehem. And the only other update I wanted to give was just our drug court. I always give an update on it. As of today, we have 58 active participants, and we've had 15 graduates. So we did have a few discharges today, but we have more coming in. We always have a large pending list of applications. So our drug court is going really well under Judge Daly's directive. So that's my brief update.
Great. Matt?
Just real quick, is on the data here, I realize you're on the way out in the department there, but I guess maybe pertinent to you is like the demographics of those that are dealing with the overdose of the mental illness. So of course we, how much that's tied together, so we can help address the mental illness. A lot of them are obviously self-medicating.
Comorbid.
Yeah.
Obviously, that is a huge thing. A lot of our individuals that we serve are co-occurring. We work closely with the mental health division, and we'll continue to do that. We have treatment providers. But a new program that we starting July 1 at the Bethlehem Recovery Center is we're actually going to have a mental health trained worker on staff at the recovery center, because we're finding a lot of people were coming in and the volunteers and staff there weren't trained in mental health, didn't know how to refer for service and what to do. So we work together with the mental health division, and we're actually putting a worker in there. She's going through the peer recovery specialist training for mental health right now, but as of July 1, we're going to put that in there as a pilot, see how that does, and then offer it out as an opportunity, because there is a need, and rather than calling the police because we don't know how to help somebody or how to de-escalate anybody, we're doing training. We're also training all of our providers on mental health. We're doing it's a piece of the CIT training that Brian Watson has offered. He's doing a smaller presentation for our providers, the recovery centers, the shelters that take in a lot of our clients. So we're offering that in July as well. So we're doing a lot more in the way of partnership, but we also offer in treatment. We have co-occurring providers.
Hi. I had two quick questions, but I'm going to ask them to you, both of them, and you can answer it any way you want.
Okay.
One is you had mentioned Narcan, and I know the cities are generally on top of this. I was wondering how that is going out in the outlying areas, and if there are any programs currently through the state or federal government to get those out there. And also, Lehigh County, Northampton Borough, and I noticed that. I know that has been an issue in recent years, and people think it's all Bethlehem and Easton. And when I did child abuse way back at another time, people thought it only happened at Bethlehem and Easton, and they found out it happened in Bangor and other areas like that too. Is there a cooperation with Lehigh County? Because I know oftentimes, I'm sure if you were to check Catasauqua, probably has as much of a problem as Northampton. Mm-hmm. So I was just wondering, I know at times we would try and foster, especially on that border, agreements. Didn't always work, but sometimes it did. So those are my questions.
I'll answer.
However you want.
I'll answer the Narcan question first. That's probably the easiest.
On behalf of Ms. Hefner, she probably wants you to be succinct.
She knows my take on some of these answers. As far as Narcan goes, at one point the district attorney's office here was giving it out to first responders. We as a division have worked with the school districts to ensure that every school district has it. We train their staff. We train the sheriffs here. We did all of that because the standing order is out there and everybody had it, and if they didn't have it, we worked with the doctor to get it for our providers. It was recently that a grant went out through PCCD for every county to have one centralized spot. So we talked with Kristen Wenrick again from Bethlehem Health Bureau, and she has taken on that task. So all first responders contact the Bethlehem Health Bureau, and they make sure that they get their supplies when they need them replenished, and then they report all their data and usage to her, which is nice because if it's coming from various spots, we weren't getting the data. She's now almost the central spot that we can actually get good, solid data. So I believe every police department is carrying it. This task force is working with all the local pharmacies. They're doing training, making sure pharmacies are aware of the standing order. Are they honoring the standing order? If they're not honoring the standing order, what can we help you with to get you on board to carry Narcan so that an individual can walk in and get it themselves? So we're doing a lot of different things. We as a county really haven't handed it out to the public. We've just made sure our recovery centers and the sheriffs and everybody that they have it, and then the first responders, obviously, because they're there. The second question, we work with Lehigh County. It is interesting because we all share the same regulations, but we're able to carry it out differently. So we're called an SCA. Every SCA, as long as you're within the regulations, how you deliver service is different. We partner on some things, so we have a warm handoff program that is all of the hospitals between Lehigh and Northampton County. We use the same provider, the same program, so everybody knows how to access treatment when someone comes into an ER. They do not have recovery centers where there's an interest now. They're coming to us, actually, to say, hey, help us out here. But they are looking to do that. It just depends on the climate of the county. We do things differently. We're very recovery-focused in Northampton County. How we do prevention, what our beliefs and our philosophies are, is different. We do try to work together if one of our residents is in their jail or their residents in our jail. Each of us will do the assessment, we'll talk to cover treatment. So we do have a good working relationship, but there's always that, this is the way I like to do it. But, They also have a B-pair program, but it's called Blue Guardian. So they have different, similar but different.
Anybody else?
I don't know. I'm just keep looking at this graph, the zip code graph, and I confirmed with my math teacher to the right. But anyway, shouldn't it be more overdoses by population? I mean, percentage of population rather than just raw number overdoses. Maybe 18015 wouldn't be quite as high if it was just the percentage of their population rather than the number. You know, like if you have 100 people and.
And I don't, this is Kristen's data, so I can't say for
Yeah,
how
but I
she,
just thought that
how
might be
she looked at it.
interesting.
I think
Maybe it wouldn't look quite as bad.
the goal was, though, to see that.
But it makes Northampton look worse because the population's smaller and
Oh.
the numbers are high.
Well, I'm looking at 18064, and that's pretty high, too.
But I think if you even look at any, you know, just one in any of
Yeah.
them is big. But the goal ultimately was where we're seeing larger volume
Right.
of people, that's where we're going to kind of target some of our interventions.
Yeah, thank you very much.
But yeah, that would
It's
be,
tough.
I mean, this is more data than I've had in years, and I'm very thankful for this because
It's excellent.
if I went by the data I received from the hospitals, Northampton County does not have a drug overdose problem. So
Wow.
I'm very thankful for this. A lot of that's prescription pills.
The CRS and the peer support, are they certifications, or do they have to go through like licensing?
They're not licensed. They do all, there's like a course, like the CPS, which is the mental health version of the peer specialist. They're going through right now, we're actually having one at the county. It's a 2-week everyday training to go through all the coursework, and then you get a certificate for it. CRS, there's so many courses they have to take. And then there are regulations kind of around it, but it's not a licensed.
Is that through the CERT board?
I'm not sure
Okay.
who does all of that. And they're different. Like for mental health peer, you have to be signed off by a psychiatrist. Drug and alcohol peers, you do not. We can refer directly to them.
So I have one more question for you, because now you're no longer the director of drug and alcohol. So what would be your wish list if you were staying? Like what? Like, 'cause I have to commend you, and having met you and see the work you do, it's phenomenal. You know,
Thank you.
and to see that you really try to cover all the bases, but knowing that there's never enough we could do about this. So what would be on your wish list if you were staying?
Well, my main wish list was the recovery center, and I'm going out with that, so I'm happy.
But nice.
Obviously, we can always say more staff, and I think Beth Miller, who is the acting administrator, will tell you that drug court is growing. So that's a goal down the road as that continues to expand. More bed availability. We can only request providers expand as much as they can.
And is that within the county or external? I mean, throughout the state?
Throughout the state, there is none, especially adolescent facilities. We have one we contract with, and it's out near Pittsburgh. It's the closest because the one in Quakertown shut down.
Right.
So that would be, you know, a little bit of ease from insurance companies on how to get people into treatment. These deductibles are killing people, and, you know, we're jumping in as much as we can. And you can never say no to funding, so funding's always a good thing.
I only ask because when we go to CCAP again, there's always information, so I just want to know what to look for. Thank you so much for everything you've done and a good presentation.
Thank you, Tiffany. And I just wanted to let everybody know Beth Miller, who Tiffany came along with Tiffany, will be our acting administrator. The posting for that, the drug and alcohol administrator, comes down, I believe, on Friday. So HR and I will take a look at those and hopefully get that filled far quicker than the MHEIDP administrator. But at least we're set there now. So I told Beth I would let her off the hook for tonight, but I just wanted to let everybody know who she was. So thank you.
Mr. Soto? Captain Sula? He's brief. He's brief to be brief. The staffing.
Okay. I'll go ahead and start with admissions, if that's okay. At this point, we are just a slightly lower than budget of 668.7 with our budget of 670. I will tell you today we are 670. We have been wavering, and that the reason for that is we do have many more male referrals than female. And of course, as we try to create male beds from females, it's a little difficult because of, you can't really, you can request and say, hey, would you like to move? If they say no, then there's nothing you can do about it, unfortunately. So we're trying to do everything we can to create male beds for those male referrals that we have. But we are trying to stay in the 670s or 672 was what I've seen in the past week. Any other questions on admissions before I move to finance? No? Okay. With regard to finance, our cost per resident per day, April to May, has gone up a little bit with regards to the staff, the residents that we have. Excuse me. That happens sometimes, when you get an increase in the amount of residents with more skilled services, and Medicare will only pay so much, so we have to kind of pay a little bit extra. But it's only slightly up, so it's not that bad. Our cost per resident per day is down for the year, and our accounts receivable are slightly a little bit up, but we're really getting them down with the staffing that we have. Our case mix index is slightly up, which is good, 0.87 to 0.88, and actually this month we're at 0.89, so that's very good for our intergovernmental transfer. Any other questions on finance before I move to nursing? No? Okay. In nursing, we have increased our PPD. It's at 2.96, which is higher than last month. It's still in the budget of 3.2, but I can tell you that we have seen a lot of days where it has been 3 and over on our PPD. So we are increasing our recruitment strategies to hire CNAs, RNs, and LPNs. Of course, we have a lot of things going on. I mean, we do not only have the recruitment, we have the retention that we're working on now. I'm in charge of the retention committee to just formalize it, and then we're going to have staff take it over, but different types of events and things that we can do to keep our staff once they've started. Also a mentoring program for our RNs, LPNs, and CNAs. Our OT is slightly upward. However, our agencies remain the same since last month, and of course the whole goal is to get that down once we have more staff starting. Any other questions on nursing? Yes.
Do we have a director of nursing?
At this time, we are currently interviewing for a director of nursing. We have looked at different avenues to go ahead and recruit. One such publication is Padana, which is it's kind of it's a publication that nurses look at, and so we can go ahead and get different resumes from there. So we are looking at that, and then we'll start our interview process.
Okay. Well, but no, just a comment. I mean, it's I know we had one that didn't work out, so essentially we've been 6 months with either an interim director or without one. And the media is obsessed about who the Easton wrestling coach is and whether or not that position is filled. So I'm disappointed that it's taken this long to find somebody, especially given the circumstances of the departure of the previous director. Thank you.
Sure.
I guess this ties in with what Mr. Cusick asked you and what happened before. Are you seeing in your search, is salary an issue for a director's position at Graysdale?
Yeah, I mean, it is...
as compared with other facilities?
Yes, definitely.
All right.
Just to answer both of you, Graysdale is a very unique facility. I mean, not just in size, but the way it is, and you're not going to get like a bunch of 688-bed facilities all around. It takes a special person who can really handle that environment, and the director of nursing job is one of the toughest job, if not the toughest job in the industry. So it's not something that you can just, it takes some time to get the right person.
I understand, and at this point, if we are committed to Graysdale,
yes,
and I mean, I know that's gone back and forth over the years, I'm certainly committed, but we may then have to realize that there's a certain price we have to pay. Some may debate whether we should or shouldn't, but I think that's something that you have to have a discussion with the administration on, and then we all have to be involved in that discussion because, I mean, if somebody comes in and they leave, or I agree that it's an important position and we need to get it filled. That's all I just want
Absolutely. Okay. Any other questions about nursing before I move to the next page on the other side, which is compliance and risk? We only had one anonymous complaint visit from the Department of Health. It was unsubstantiated, so no deficiency was received. Any other issues before I go on to quality measures? Okay. Quality measures are trending downward with the exception of long-term pain, facility-acquired wounds, and total number of residents with wounds, which are just trending very slightly upward. So, I mean, it's barely even a change, 77 to 79. You know, but we're continuing to work on our efforts to go ahead and reduce our wounds and, of course, reduce our falls.
May I ask a question?
Yes.
Yes, I'm sorry.
It's okay. I asked. That's important.
Thank you.
The wound care teams, are we light in the third shifts for the wound care?
No. I mean, we are consistent with our wound care team and also with our wound care consultants who assist the wound care team, you know, with what they're doing and looks for different types of interventions. So we're actually right on point with that.
I guess
wouldn't say we're
the
light.
question was, do we have enough wound care personnel to take care of all the shifts that we need?
Yes.
Okay.
Go ahead.
Are we okay now with? I'm sorry. Are we all right now with the sentient bed mattresses, the air? I mean, are we?
Yes.
Okay. I mean, we were having issues.
Yeah.
But okay.
Those issues have been resolved. We've had the vendor come in and deal with a lot of retraining and information, and any issues that we had have been corrected.
Great. Thank you.
Things are much better. Okay. Any other questions with regards to quality measures? Okay. Our satisfaction survey is at 4.28, which with our benchmark of 3 is much higher, which is very good. Now I'd like to move to human resources nursing. Okay, as you can see over here, sick call-outs have increased while our FMLAs and IFMLAs have decreased slightly. If you see our RN turnover rates, we are not changing in our RN turnover rates, but our LPN and CNA are just slightly up. And our CMS star rating remains the same as it was last month. Any other questions?
You had
People forget that. Could you comment on a policy, or if this is a new policy, stating that they won't give employees copies of PPDS or Hep B vaccines that were given at Graysdale? Are employees allowed to have that, or will you give that? They said it's a new policy, and failure to produce or refusal to produce patient documentation is a CMS violation.
Yeah.
That's all I've heard.
I'm going to have to look into that and investigate it further and have an answer for you, if that's okay.
Yeah, I would appreciate that.
'Cause, yeah, so I can find out exactly the right answer for you. Any other questions? All right, thank you so much.
Thank you. You're the only one left.
Yes. My list is long, but I will keep each item brief. But I'll follow up on the, on Graysdale, since we were just on that topic. We have been looking at new areas for targeted recruitment for directors of nursing. And I have learned that there is a shortage of director of nurses across the board. This is not unique to us. So we are working on ways that we can better recruit. I spoke to someone that I would consider a very qualified possible candidate who declined with the salary. So that answers your question. I do have another initial phone call with somebody tomorrow. I will remain optimistic until otherwise.
Sure. Okay. With its size, I mean, is there any practicality of having two, because of the size of the facility, is there any logical way to have basically two director nurses,
Co-director?
or something?
I don't know. I'm not saying it's not something we could consider. That's certainly not a question I can answer without consultation with a team of folks.
Yeah.
Certainly nursing home facilities is not my area of expertise, but
Yeah, but
I think it's reasonable to have one director of nursing. I'm not saying two wouldn't work as well. It's a possibility. I think salaries are our biggest barrier for finding the right qualified person who will be able to manage a facility of that size to our satisfaction. So, however, we did bring back Beth Berklight part-time. She is retired, DON? DON? Yes. Thank you. I just couldn't remember if she was the assistant DON. The DON. 2 or 3 days a week. So we have her for the next 4 months until her daughter has her baby. So she has been a big help and also brings back with her some of that longevity and experience. So hopefully we can even just get some better systems in place over the next few months or moving forward as we hire a DON.
Excuse me, Madam Chairwoman, may I ask a question? Do we know, or we check the regulations, I mentioned regs, is there a concern by a certain period of time without a director of nursing? Could that put us in any jeopardy with the state or feds or anybody?
No, not to my knowledge. We still have Kim Reinmiller as our acting DON, so we're in good shape at the moment. Okay. So we have a new volunteer coordinator. Mike Colon had filled that position, and so he's now in admissions, and Jenny Repscher, who was the executive secretary, filled that position. So we are just recycling our folks at Graysdale, and we will continue to do that. The good news is we get folks and keep them internally even when they're ready for something new, but it still leaves us in a lurch trying to move forward. Our risk manager, investigative nurse, is retiring in July. So we have already started, that's been posted for going on 3 weeks. We have several potentially well-qualified external candidates that we are working on setting up interviews with. So the goal is to ideally have someone selected in the next few weeks, but the person who currently fills that position is willing to come back as a contracted employee on a part-time basis to train her replacement, which we're very appreciative of because that is honestly a bizarre job that does about 35 different things, many of which are unrelated. So that will be a big help from her. And exciting news for Graysdale, we did just receive the official word that we received the Advanced Quality Assurance and Performance Accreditation, which we call QAPI. So we have monthly QAPI meetings at Graysdale. It's essentially the nuts and bolts of what you see. QAPI, it's what I didn't make it up. Well, I at least spelled it out for you first, Mr. Ackman. So that is actually a very big deal. The press release, I believe, said an exceptionally small percentage of nursing homes have that accreditation. So we're really excited about that. However, we still have many things to work on, and we will continue to do so until we get it right. There's still some things we're trying to figure out, and we will, and we will rectify them long term. Any questions about Graysdale? Okay. Let's talk about our aging division. So I have identified the replacement for John Mailer, and now it is just pending civil service approval, and I'm not anticipating any difficulties, but you never know. So hopefully we will have that answer. Aging, the civil service folks with aging are much quicker to respond to us, so hopefully honestly, I'm hoping in the next week or two we have an answer, and then we can make that announcement. And we've been talking about the protective services folks and our audits. The state is actually coming tomorrow to do, or they were there today, I'm sorry, to train our information and referral folks on improving the quality of the assessment at the front end. There was a few areas that they needed to work on, and we're more than happy and pleased to have the training because it's been an area that's been lacking. So we've been really pleased with the state. They've been exceptionally helpful with their technical assistance for us. So that was today, and in fact, the ombudsman folks from the state are coming tomorrow to provide us with some technical assistance for that portion of our aging program as well. Questions about aging? Okay. Children and youth, staffing, still an issue. Civil services, I told you all about that having shut down. It is up and running, but we still have yet to actually been able to hire our first person since the system is back up and running. So it's a juggle at best on a daily basis, and we are managing, but it's challenging.
Unable to hire because of needing to wait for them to make the approval?
Yeah, just one quick example. Civil service for these positions, caseworker positions, you have to go to Harrisburg and take the test. So you can take a caseworker 1 test and a caseworker 2 test, part of which is the same, but you still have to repeat it twice. And so some folks went and they weren't approved as caseworker 2s, meaning they didn't get a high enough score, but they wouldn't rate their caseworker 1 test, and they said, no, you didn't really take it. And you can appeal it. That takes 6 months. It's honestly one thing after another.
They'll only get administered in Harrisburg now? I mean, they used to.
Well, there's some that are online, Mr. Heckman, and I actually could be wrong. The caseworker could be online. There are a portion of them that you have to go to Harrisburg, and there's a portion that are online. I don't know which is which.
It's hard enough. I mean,
Yes.
the state's doing something silly. I think we'd like to know. And also, if I may, very quickly, if I may, very quickly.
I can talk over that hand.
As far as civil service goes, is the state making progress on separating out child protective service workers so that you can have a better chance of paying, maybe, and keeping, so they don't immediately jump to other divisions?
Not to my knowledge.
All right.
Not to my knowledge. But I will tell you, one of the things that seems to have come out of the Auditor General's
Yeah, I think he
report
took that up, yeah.
was the ratio of caseworkers to supervisors. So next year, we are looking at having to be at a ratio of 4 caseworkers to 1 supervisor. So in addition to me coming back in July for the Personnel Committee meeting for all the positions the state approved for us for this calendar year, next year it will be probably an equally large number because of simply being at, I think we are around 5 or 6 caseworkers to 1 supervisor now. So things are changing, and some of them will be for the positive, but we'll just have to wait and see how they play out. But we are in the process of, I guess for apparently the last 6 or 7 years, they've been trying to get the state to approve another General Protective Services Program Director, which they finally approved. So we conducted interviews yesterday, and we'll have that decision by next week. We hired Maura McGuire as our managing attorney for children and youth, and brought on another attorney as a contracted employee for the moment. And come July, we'll be hopefully requesting the 3rd attorney that the state has provided us with for children and youth. So I think Mara is finally feeling like she can breathe at least a small amount, but she pretty much works day and night and all weekend long. So we're really happy that we have somebody else for her. Questions about children and youth? Okay. Then just to briefly touch upon the MHEIDP, so Mental Health Early Intervention Developmental Programs. As I already said, Tiffany is our new administrator. She has spent her first week thus far just trying to meet with everybody, get a handle on what the issues are. There are many, and try to figure out which she needs to tackle first. And based on what I've seen with Tiffany and what I've heard about her work for the last 5 years in drug and alcohol, I'm really excited to have her in that position. I think she's going to do a lot of great things. So the one other exciting thing with mental health that we are doing, we are partnering with 2 of our providers to do forensic ICM, which is intensive case management, in our jail. So for the folks with mental health issues who are in our jail, first of all, I learned they generally have to wait 4 months before they see the psychiatrist. This is not new to most of you, I'm sure, except that in order to be released from jail, they have to have been seen by the psychiatrist and have a diagnosis to be placed in the most appropriate placement. So we are hoping that the 2 providers that we are going to use will, the goal is obviously to help get those folks through the system and navigate the system more efficiently and quicker so that they can be released sooner and not spend unnecessary time incarcerated because they haven't seen a psychiatrist.
I asked at the jail meeting last time, does the state law require it be a psychiatrist, or are APNs allowed to diagnose?
So I just asked clarification of this the other day of our health choices person, and for behavioral health with medical assistance, it has to be a psychiatrist. However, the state recognizes the extreme shortage of psychiatrists and the delays this causes in treatment, and they are moving towards Certified Registered Nurse Practitioners, CRNPs, being able to do the same thing. So I asked the projected start date for that, and the best guess somebody could give me was the beginning of next year. So we're still a ways out. Other questions? Okay, I had a couple more things. They're not super urgent, and I know you all want to take a break, so I'll end it there for tonight if nobody has any other pertinent questions.
People are glazed over. I think you did a great job. Thank you.
Thank you.
Motion to adjourn.
Sure. Oh, yes.
Thank you. Meeting is adjourned. Oh, we don't have to?
I'm still caught up on the Robbinsville Metro.
Oh, dear goodness gracious.
And I guess the next question is, did you get caught in the rush hour for traffic? That's the next question.